Okay, in this video we're going to be going over necrotizing enterocolitis. It's a very serious condition. It's actually the most common GIT emergency in newborns. It affects mostly preterms, but every once in a while it affects a term baby as well. So what is necrotizing enterocolitis? It is a mucosal or even a trans-mucosal necrosis. And this necrosis of the intestine can oftentimes lead to perforation. So what can cause this? First thing is prematurity does seem to be the number one factor, prematurity. And this is evidenced by the fact that the incidence and fatality increases with prematurity. So the younger the age of the gestational age of the baby, the worse the outcome becomes, and the more commonly it's seen. So pathogenesis is related to three, underlying factors, and it's called the triad. So the first factor is going to be intestinal ischemia. So this can be any event which leads to the bowel becoming ischemic. The second thing is going to be enteral nutrition. So what the baby is eating and how often will play a role in necrotizing enterocolitis. And finally, it's going to be bacteria and other organisms, primarily bacteria in the gut, can influence this. So this is kind of a triad here for the pathogenesis. So let's first tackle enteral nutrition. So what tends to happen is the infant, when it's a preterm, the gut isn't completely working correctly, and so there's decreased motility and function. And so what that means is whatever it eats stays in the gut, and since it's not absorbing it, it's great for the bacteria. So the bacteria starts taking up all this extra food, and then you get increased amount of bacteria in the gut. And this is one of the reasons why aggressive enteral feeding of an infant, of a preterm, aggressive enteral feeding of an infant can predispose to necrotizing enterocolitis. So with preterms, you don't want to necessarily overfeed them as much as you would like a term. And actually, human milk tends to still be a little bit better, tends to be better than formula milk. So it's much more important for the preterm babies to get this human milk, and it's most likely because of the fact that human milk has IgA and other protective effects. Now with bacteria, so normally, of course, we all know there's a normal flora of bacteria. However, in the preterm infant, you have a few problems that arise that can predispose these bacteria to overgrowth and eventually, causing ischemic intestines. So the first problem is related to the integrity of the barrier. So there's an immature barrier. So the tight junctions that we would have, or a normal term infant would have, a preterm infant doesn't have. And so that allows the bacteria to penetrate through the gut and into the blood. The other thing is going to be they have an immature immune system, so immature defense system, including the IgA and the lysozymes and all the other symptoms that most other people will have. And finally, they also have a high level of pH. They haven't really made their stomach very acidic, and so this makes it more difficult for them to tackle some of the bacteria. What kind of organisms do you find? One of the most common organisms is a staph, but it's the coagulase negative staph, which can be epidermitis and all that. But there are other bacteria that is commonly found, E. coli, Klebsiella, even Clostridium perfringens, and even viruses like a rotavirus. But again, it's not necessarily that you will find these bacteria. This is just commonly associated organisms. And just to highlight the fact that the flora does play a big role, oftentimes giving empiric antibiotic for more than 5 days can predispose to this necrotizing enterocolitis as well. Okay, finally we can take a look at the intestinal ischemia. This is usually the problem with term infants. So term infants don't usually get necrotizing enterocolitis, but term infants that have congenital heart disease or some type of perinatal asphyxia, even any type of respiratory condition, polycythemia. So anything that would decrease the blood flow to the intestine can predispose to necrotizing enterocolitis, and this is highlighted by the fact that indomethacin is oftentimes associated with this. And what indomethacin does is it causes contraction of the splanchnic vasculature, and so that can lead to this ischemia. So these three underlying pathologies predispose to necrotizing enterocolitis. So that is, I guess, the pathogenesis. Let's just move on to the clinical findings that you would find. So initially, the patient might be doing okay. It presents generally in the first or second week. However, 25% of the time, it could even be greater than 30 days. So even a month later, you can sometimes have this. And interestingly enough, the more premature, so the greater the prematurity, the later it may show in gestational age. So more premature, the later you'll see it. So the ones that maybe come in 45 days or 50 days later, they'll be extremely premature babies. So that's one interesting fact about this as well. So what is the initial kind of symptoms that you want to be aware of? It starts off, usually pretty slowly, but sometimes it can be very acute. But generally they have decreased feeding intolerance. Sorry, not intolerance, decreased feeding tolerance. So they're not able to take feed like they were when they were first born. And then this, slowly they'll have distension, and then, the vomiting and diarrhea begin to develop. So these are kind of, and then when they get the diarrhea, it's bloody. 25% of the time it's, you can just see the blood, but oftentimes it's occult. And so here is an image, as soon as it loads, of a child with necrotizing enterocolitis, and you can see the enlarged abdomen here. So this is kind of a big, kind of getting too big, it's getting smaller. Okay, and so in this child, you can see how the abdomen is distended, and it's red from the ischemia, and the blood is occurring below. Now, once you get this condition, this will then can go into many different ways, into three primary different ways. The first thing that can happen is the child can get sepsis. They can also get DIC, and they can get perforation, or they can get all three. So these are kind of the major problems that occur. So if they get sepsis, they'll get the classical conditions of sepsis, such as the hypotension, the temperature instability, the lethargy, the neutropenia. So these are going to be classic signs of sepsis. DIC, you get the bleeding and the thrombosis that occurs. Perforation, this is probably one of the more serious conditions as well. If there's perforation, this is immediate surgical case. And generally, what you'll see when there's sepsis is, perforation, is they'll have pneumoperitoneum, which is evident on X-ray, and portal venous gas. So this is going to be gas in the venous system. So generally, you can see this in the liver. This you can see on X-ray, but ultrasound probably shows it a little bit better. So once you suspect this clinically, what would you want to do? What type of investigations would you want to do? The first investigation that you want to perform is an abdominal X-ray. So the first thing we want to do is an abdominal X-ray. And this can generally confirm your diagnosis. So this is generally enough to confirm the diagnosis. You can do it in supine, but if you're worried about pneumoperitoneum, supine might not be the best
way to go. And you can't actually, ask the infant to stand. So what you do is you put them in the left lateral decubitus position, and then you try to look for air in the abdomen. So this is kind of, not the usual way of going about it. What will you see? You can generally see gas in the intestines, and the big word for this is pneumatosis intestinalis. And so this is just a big word for gas in the small intestine. And of course you'll see these dilated loops. So that's classically what you would see. After this, you might want to also consider doing an abdominal ultrasound. Abdominal ultrasound will also show you pretty much the same picture. You're going to get gas, but of course you can also see any fluid collection that might be there, and you'll also notice that the bowel wall is thicker than usual. What's the additive effect on this is you can do an hepatic ultrasound, and there you can try to see if there's any portal venous gas, which can also suggest a perforation. You might have a perforation but not necessarily have pneumoperitoneum. So this additional study of looking for portal venous gas can maybe help diagnose pneumoperitoneum with perforation without pneumoperitoneum. So it's a good study to do. After this, you probably want to go for some labs. Labs aren't going to help you with the diagnosis, but it does help you with monitoring and kind of ruling out some of the other complications that do occur. So the first thing that you want to do is, the main thing I guess we want to use it for is to establish a baseline. You want to go for CBC with the differentials. You won't find anything specific. If they have neutropenia, severe neutropenia, less than 1,500, it is a poor prognostic sign. But what's really interesting is looking at the thrombocytopenia. The thrombocytopenia is a good marker for necrosis. So if you have decreased platelets, that probably suggests that there is necrosis going on. And if you're increasing the amount of platelets, that probably means the patient is getting better and there is some resolution occurring. You might also want to do coagulation. This would be if you're suspecting DIC. And as well as that, you might want to look at some serum markers or some serum electrolytes. Generally, the hyponatremia, hyperglycemia, and acidosis, metabolic acidosis, generally suggest necrosis or sepsis. So this is a good way to monitor these symptoms as well. And if there's any respiratory problems, you might want to do arterial blood gas to monitor the respiratory system. And finally, you do want to do a sepsis workup. A sepsis workup consists of a blood culture, a stool culture, and if you feel like it's necessary, a CSF culture. And in the stool culture, you also want to look for occult blood, because of course in necrotizing enterocolitis, that's a very common condition that can occur. So what are differential diagnoses? So after you do this, you do kind of have a few things that you need to rule out and kind of compare with. Your main differential diagnosis is going to be some sort of obstruction, like a volvulus that can present like this. The other thing can be a rotavirus or an enterovirus, because they do present with bloody stools. However, this will be more clustered. That's what you tend to see. Another differential diagnosis you want to think of is cow milk protein allergy. So of course this would have to be, they're on formula. However, with this one, as time goes on, the stool amount increases and the frequency increases. So that's a telltale sign that you might be dealing with that. And you can also just have a spontaneous intestinal perforation. However, when it's spontaneous, you tend to get a bluish discoloration of the anterior abdominal wall. So that kind of helps you differentiate that. And there's a few others, but these are kind of the main ones that I came across. So you have a patient with this, you've confirmed it. What will be your management strategy? Initial management will be supportive. So you want to first, because this is kind of acute crisis oftentimes, so you want to do the supportive measures first. This will include, first you want to give bowel rest, and you will do this by giving them TPN. So TPN is when you just give total nutrition through the venous line. The other thing you want to do is nasogastric suctioning. And you want to keep doing this to make sure the bowel doesn't get inflated, and this decreases the risk of perforation. And you want to keep doing this until they improve. If they have any cardiovascular or respiratory problems, you want to address those with whatever is necessary, and you want to make sure you give them IV fluids. You want to correct for any electrolyte, acid, or DIC symptoms that might occur. After that, your next main focus is going to be giving them antibiotics. You want to go broad spectrum. You want to cover as many different types of bacteria as possible. There's so many bacteria that can be involved. Going broad spectrum is probably your best idea. Empirical treatment, there's a few out there. Nothing's really been proven. Every hospital tends to have their own protocol, so it's not really worth giving you specific antibiotic or regimen. And finally is going to be surgery. And you do want to make sure a pediatric surgeon is involved, because the decision to make surgery, to do surgery or not, is not straightforward. We do know if there is any sign of perforation, then you go directly to surgery. You do not wait. So that makes it easy. But oftentimes, these patients are very acutely ill. They're infants. They really can't handle a surgery. So you really need to weigh both options. The two surgical options that you have is a laparotomy with resection. Of course, this can lead, if you resect too much bowel, it can lead to short bowel syndrome, which can lead to malabsorption. And the other option that you have is primary peritoneal drainage. So what they do is at the bedside, they'll make a little stab wound right where the McBurney's point is, and they'll keep draining it in the hopes that eventually the patient can heal on his own and without the excess fluid there. And this is preferred if they're extremely low birth weight. So in these circumstances, it's better because these patients will not handle the surgery well. So this is kind of a baby step option. So what are the complications that you can expect? Well, there's acute complications and there's chronic complications. So acutely, we've kind of already discussed them. It's sepsis, DIC, you can get CVS and respiratory collapse, and there's obviously metabolic complications such as low glucose and metabolic acidosis. So these are the acute ones. Then there's also some chronic. Two main ones here. The first one is going to be strictures. So when the intestines heal, they might cause some strictures, and this will lead to bowel obstruction, and you can see worsening symptoms after improvement. And the other thing is going to be if they undergo surgery, it's going to be short bowel syndrome. And with short bowel syndrome, what happens is if you've taken too much intestine out, the infant cannot absorb enough nutrients, and so he needs to be constantly on TPN to get his nutrients. And then being on TPN for a long time has other problems as well. Can affect the gallbladder and those issues. Luckily, 50% have no sequelae, but the mortality does range between 20 to 40%. And again, this increases with prematurity. So the more premature they are, the higher the mortality. There are some prevention methods that you can do with most preterms to try and get away from this complication. First thing is breastfeeding tends to be protective, and if they're very low birth weight, you want to try to do as minimal enteral feeds as possible, because aggressive enteral feeding has been shown to predispose to necrotizing enterocolitis. But at the same time, you want to make sure that because they're getting low fluids, you have judicious volume advancement. So you want to compensate for the low enteric feeding. And finally, probiotics, trying to give them normal intestinal flora to kind of crowd out the pathogenic intestinal flora is another way to try and limit the complication of necrotizing enterocolitis.